presented by David James, coming from Imperial College, London, United Kingdom.
Good afternoon, ladies and gentlemen. Mr. Chairman, thank you very much for this opportunity to present my work entitled The Neuroergonomic Assessment of the Robotic Enhancement of Surgery. I have no disclosures. It's undeniable that minimally invasive surgery has brought about clear benefits to the patient. However, it is associated with challenges for the surgeon. And in part, some of these challenges have been met by surgical robotics. However, we feel it is imperative that we need to assess the impact of performing these tasks on the user. And this essentially is the field of ergonomics. However, in the age where we're putting more and more burden on our surgeons, they're immersing them in their operative environment with operative consoles and enhanced technology, we feel it's important that we actually look towards the surgeon cognitive behavior to see if we can understand whether this is actually, at this level, are we actually helping our surgeons? And this is the field of neuroergonomics, which is a sort of a combination between neuroscience and ergonomics, and it's the study of the brain and behavior at work. In order to assess brain behavior, we use near-infrared spectroscopy, which is a non-invasive neuroimaging modality, which, as you can see here, we have optodes which emit infrared light, near-infrared light, and this light passes relatively freely through the skin and the skull. They can be positioned on the surgeon's head, according to whichever bit of the brain you're interested in, and then the light is scattered by hemoglobin, and it's scattered differentially according to whether it's oxy or deoxyhemoglobin. If the surgeon's using their brain, which we would hope they would be, you see a classic pattern of activation whereby you get an increase in oxyhemoglobin and a sort of a late decrease in deoxyhemoglobin. And this is based on the principle of what we call neurovascular coupling. If you're using that bit of the brain, then the blood flow to that bit of brain will increase. And this underlies the principle of functional magnetic resonance imaging scanning as well. However, our technique, NIRS, which is widely available, is easy because we can use, our surgeons can do tasks in a more natural environment. So we've used this technology to assess a particular piece of robotic surgical equipment called Gaze-contingent motor channeling. Now, gaze-contingent motor channeling is a tool that is used to improve surgical performance. It improves accuracy. And how it works, as you see, the task is to track a target, which is a black dot, on a simulated beating heart. With the GCMC enabled, the surgeon's gaze behavior is detected by the eye tracking system underneath the monitor. Then this information of where the surgeon is looking is used to constrain their hand, so therefore to push the tool that they're operating with towards the target. And we know that this improves accuracy. We tested 21 subjects performing this task, this tracking task, both with and without gaze-contingent motor channeling, and we randomized them according to which they performed first to sort of minimize any learning effect. We assessed accuracy as the distance from the tooltip to the target, i.e. how well they did it. And whilst we did that, we measured the cortical blood flow over their prefrontal cortex. And this is a region involved in higher cognitive function, including error management. Now, our results. The task was performed in one sitting, but we repeated 5 blocks of tasks. So that's what we're seeing here. And in red is with gaze-contingent motor channeling. And you can see that the error, which is the distance from the tooltip to the target, is actually less. And this was a significant difference when the GCMC was enabled. We also found, with regards to the cortical blood flow, that when they were using this tool, there was more prefrontal cortical activity. And again, this was significantly different from the group without GCMC. So, in conclusion, we've demonstrated that it is possible to measure cortical activity whilst performing surgical tasks. And also, we've shown that cortical activity has been modulated by this robotic tool. And we believe that possibly what's happening is this tool is forcing our users to employ a different strategy to complete the task. And this has resulted, in this case, in improved performance. With regards to ongoing work, we're looking into the longitudinal assessment of what happens as people are actually learning this task. And we're also measuring the efficiency of cortical interactions between different regions. And in particular, as you can see here, we're looking at interactions between frontal and parietal lobes. And these are the regions that subserve hand-eye coordination. So we want to know, is our equipment making the brain behave more efficiently? And we believe that ultimately we may be able to use surgeon brain behavior to guide the development and design of novel surgical technology. Thank you very much.
This paper is open for discussion. Any questions from the audience?
If I could ask a question, did you look at the difference between 3D and 2D, and if the subject worked in those two environments, was there much difference?
That's a very good question. This particular study was performed in 2D. However, we're also in the process of doing work within the Da Vinci console of enabling 2D and 3D and looking at the difference there, particularly at the occipital cortex underlying vision. So that's work that we're actually looking into, which is very interesting.
Hello, Lucian Panait from Connecticut. Did you look at differences between novices and more advanced surgeons? There are some studies in the literature that suggest that less prefrontal cortical activation happens in advanced laparoscopic users. Did you find the same?
Yeah, again, very good question, and that's very pertinent because we do know that the prefrontal cortex usually does attenuate, so the amount of activity that you see does attenuate with expertise. Now, in this particular study, all our subjects were novice to the task. However, what we've actually done is, and we do have some backup slides here, we've followed these people up. Well, sorry, actually, this is a different group, over 6 sessions on separate days. And we did find that eventually, as you see on the 6th session, that the blue means less activity, that this prefrontal blood flow did actually reduce. And also their parietal blood flow, it kind of focused in the posterior parietal cortex, and that these changes happened more quickly, i.e. they happened by the 3rd session when they were using our robotic tool, compared to without.
Very interesting. Thank you very much.
Thank you very much, Dr. James.
Thank you.